Hello and welcome to another edition of GlomCon interviews on practice-changing clinical trials, where we discuss landmark trials and emerging therapies in glomerular diseases with world-renowned GN experts. I'm Manasi Bapet, a nephrologist at Kaiser Permanente Walnut Creek in California. Today, we will be discussing emerging therapies in APOL1 mediated kidney disease, and joining us to talk about it is Dr. Kirk Campbell. Dr. Campbell is the Irene and Dr. Arthur Fishberg Professor of Medicine and inaugural director of the Mount Sinai Center for Kidney Disease Innovation at the Icahn School of Medicine, Mount Sinai Hospital, New York. Dr. Campbell received his medical degree from the University of Connecticut and completed his internal medicine residency at Yale University before pursuing clinical nephrology and postdoc research training at Mount Sinai. He's the president-elect of NKF, and a member of the board of directors of the NephCure Foundation, and sits on editorial boards of several major nephrology journals. He's also one of the lead authors on a major study published last year on Inaxaplin for proteinuria kidney disease in persons with APOL1 variants, and we will be talking about that and much more today. So hi, Dr. Campbell. It's such a pleasure. I'm so thrilled to be talking to you today about APOL1 mediated kidney disease. Thank you so much for joining us.
Thank you so much, Dr. Bapa. Really great to be here.
To start off, could you shed more light on the kidney disease burden in patients who have high-risk APOL1 genotype?
Yeah, sure. So APOL1 variants have been associated with non-diabetic kidney disease, and a lot of what we know is from population-based studies in the US, UK, and some emerging data from Africa, right? It's been estimated that in the US, approximately 10 to 15% of African Americans have two APOL1 high-risk alleles, and that's considered the high-risk genotype, really having two copies, right, of this mutant APOL1, right, G1 or G2. So having both would confer increased risk of kidney disease development. What's interesting is that only about 25% of individuals with those two high-risk alleles, that high-risk genotype, actually get kidney disease. So it's incompletely penetrant. Having the high-risk genotype is in no way a guarantee that someone will get kidney disease or progress towards dialysis. A second hit is clearly required, and that second hit is different, right, in different parts of the world, and based on different exposures, etc. We obviously saw during the height of the COVID pandemic a number of case reports of collapsing glomerulopathy with COVID infection in individuals who had high-risk APOL1, so that COVAN, if you will. We've known that HIV-associated nephropathy is highly associated with the high-risk alleles as well, and some types of the standard FSGS as well, and hypertension-associated kidney disease, lupus nephritis, sickle cell nephropathy. So there have been some associations, but the phenotype is quite variable, right? Some of these conditions are, by definition, inflammatory, fulminant aggressive. Some are more slowly progressive. So we still have a lot to understand around the etiologies of these second hits and how disease will progress in individuals. What's quite remarkable is that as we also look at the population of patients in the US who require hemodialysis, who are African American, about 40% of them also have high-risk APOL1 genotype. So, we clearly, are missing a lot of these patients, and traditionally we haven't had a lot to offer in the way of therapeutic interventions to slow the progression of disease.
Wow, it just seems like we've come such a long way in understanding APOL1 mediated kidney disease, but there's so much still that we don't know, especially in terms of the epidemiology. Could you highlight on some of the gaps then regarding the APOL1 kidney disease?
Right. I think that there's certainly a lot of gaps that are remaining around epidemiology. We are seeing some interesting phenotypic differences from reports out of Brazil versus sub-Saharan Africa versus the US. And, much like other conditions in nephrology, take IgA nephropathy, for example, it's quite conceivable that we're going to have different disease courses, different pathogenic, cascades that are important, and different responses to treatment in different geographic areas. This may be more heterogeneous than we realize. So we really need more epidemiologic data from a global standpoint, population-based studies, more screening, more registries, so we can better understand the disease course overall. It's exciting to see clinical trials in this space. In particular, I'm sure we're going to talk about some of these trials, but it's important that the trials themselves represent the true burden of disease globally, right? So that we can again understand how local characteristics and exposures might impact the response to therapy for individuals in those countries, and those in who might move to other countries in the future as well, right? So we really need to get a good sense of the differential response to therapy based on unique environmental exposures. And we also need to understand how APOL1 might be different in an individual with, say, the classic hypertension associated kidney disease versus somebody who has lupus nephritis or an inflammatory cascade that's perhaps enhancing increased expression of the APOL1 gene. And for some of the trials that are emerging, will different individuals based on that phenotypic readout and underlying pathogenesis respond better to certain types of treatment that might block the function of a mutant protein, for example, versus reducing the expression of the gene encoding APOL1.
Absolutely. So in terms of the clinical trials, can you elaborate on the mechanism of the newly developed targeted therapy Inaxaplin for APOL1 mediated kidney disease and the phase 2A trial that was conducted last year?
Right. So the phase 2A Inaxaplin study was designed to test the efficacy and safety of the small molecule inhibitor Inaxaplin that targets the abnormal ion flux function of APOL1 mutant protein, right? Fundamental work by a number of investigators, including Ope Olabisi and others, have really shown that the mutant APOL1 protein can function as an ion channel that promotes potassium efflux from cells, perhaps more sodium influx. So the small molecule inhibitor targets that abnormal channel function and was shown in that phase 2 study that was limited to patients with biopsy-proven FSGS to reduce proteinuria by about 48% over a 13-week period. So again, this was a proof of concept study. Patients were required to have 2 APOL1 high-risk alleles, required to have biopsy-proven FSGS. And this was not a randomized study, right? A single arm, but it did appear that the drug was well tolerated, and again, as we mentioned, reduced proteinuria during that period of treatment by about 48%. So this, of course, has now set the stage for an ongoing phase 2-3 study that's not limited to patients with FSGS, but individuals again with 2 APOL1 high-risk alleles with proteinuric kidney disease who do not have diabetes, and again designed to test the efficacy and safety of Inaxaplin in that patient population.
Fantastic. And do you think there are any lessons learned from the earlier phase 2A and the currently ongoing 2-3 trial, and for some of the further therapies that are coming up or will be studied in clinical trials in the near future for APOL1?
Yes, I think there's a very important lesson learned. I mean, one is that we can do precision medicine-based trials in nephrology, which again is not something that we want to take for granted. The idea that we're going to, enroll for a clinical trial based on genetic test and offer treatment targeted to, right, the result of that genetic test and the encoded mutant protein by these disease-causing genes potentially is something that's a landmark, right? That's a breakthrough, something that should be celebrated, and there are, of course, other trials now ongoing in nephrology that are precision-based in terms of enrollment. And I think that's exciting that we have hope, right, to offer patients, who have often, not participated, as highly in numbers in nephrology trials, right? Patients of African ancestry. So I think that's good. And the other thing is that the point that this drug was well tolerated is also encouraging. It will be interesting again, as we discussed earlier, to see if there are any differences in the treatment response by subgroup, because this is not a study that's limited in the phase 3 component to patients with FSGS, right? Again, APOL1 kidney disease, as we mentioned, is heterogeneous. So whether or not there will be a differential treatment response based on the actual histologic diagnosis or phenotype of the patient beyond having proteinuria is something we're certainly going to learn more about in the study. And of course, there are other emerging therapies, right, for APOL1 associated kidney disease. There are other small molecule inhibitors of the mutant protein that are being developed. There are antisense oligos that are targeting the expression of APOL1 overall, and so may reduce the overall expression of the mutant protein. Cytokine inhibitors, JAK-STAT inhibitors that might reduce, again, that inflammatory cascade that upregulates APOL1 expression. Work by Simone Sana-Turki and others have identified an N264K protective APOL1 variant that is the basis for development of another small molecule modulator, right? That could be also promising. So I think there's a lot of activity happening in this space, and there are, again, important lessons to take away from the phase 2 study and building on that success in that preliminary readout of reducing proteinuria.
It's just mind-boggling, really, to know we've come such a long way to know more about APOL1 mediated kidney disease and all these emerging therapies. And like you said, we're really heading towards more and more patient-centric kidney care, pretty much with respect to all the diseases and in nephrology in general. In 2022, the ASN and NKF task force recommended immediate adoption of the 2021 CKD epi-creatinine equation, which estimates kidney function without a race variable. And this had many downstream consequences, like higher estimated prevalence of CKD and earlier kidney transplant referrals among Black individuals. And that was such a major change in our field. What are some of the other solutions that the nephrology community should be striving for to end inequities in kidney health?
Yeah, certainly, the way we estimate kidney function has drawn a lot of attention in recent years, but certainly there's a lot more we can and should do to reduce inequities in the delivery of kidney care. And certainly, we have to increase our capacity for screening for chronic kidney disease in high-risk populations, right? There's really been some concerning statistics around the number of individuals with kidney disease who don't know they have it, right? It's estimated that up to 90% of patients with chronic kidney disease may not know that they have it. And, we've also known that up to 40% of patients crash into dialysis in an unplanned manner, right? Without getting long-term nephrology care. And a lot of those patients are from disadvantaged backgrounds. And so, we need to identify patients earlier. And I think the identification of the association between these APOL1 high-risk alleles and the risk for chronic kidney disease, if anything, it's given us another tool, right, that we can utilize to identify patients at higher risk, right, for disease progression by implementing genetic testing in a safe, ethical, equitable manner. I think we also have a number of novel agents, right? SGLT2 inhibitors and other drugs that are slowing the progression of kidney disease. But, we know that they're not getting to the patients at highest risk, right, for progression, right, in the manner that they should. So the way we implement and execute a lot of these advances and novel therapies will be a challenge for us as a community, quite frankly. And I think with all the excitement around clinical trials, there's more to come. Exciting pipeline. We've never had as many clinical trials for IgA nephropathy and diabetic disease and hypertension, etc. So we have to make sure that the clinical trial populations really reflect the burden of disease in the communities across the country and the world, right? This is how we're going to develop safer, more effective drugs ultimately, right? So I think these are all challenges we have to take upon us. So, I think the great work by the task force was a beginning, right? But I think there's a lot more that we can and should do as a community.
Absolutely. And all I can say is that's the perfect note to end. It's such an exciting time right now to be a nephrologist. And thank you so much for all the work that you and all the other investigators like you who are doing exciting work in this space and beyond. It was such a pleasure talking to you today. Thank you so much again for joining us.
Thank
Bye
you.
bye.
Thanks again. Great being here. Thank you.